Fall Prevention: The Impact of Effective Delegation and Leadership by Alyssa Benoli with Widener University. Why is fall prevention important? Accidental falls are among the most common incidents reported in hospitals. According to the article Epidemiology of Hospital System Patient Falls, a retrospective analysis, falls constitute up to 70% of inpatient accidents. About 25% of falls in hospitalized patients result in injury, and 2% result in fractures. In addition to fractures, other serious injuries include subdural hematomas, excessive bleeding, and may even result in patient death. Patients who have serious injury related to a fall during a hospital stay average 6 to 12 days of additional hospital time. Why are our patients falling? Risk factors can be grouped into two categories, intrinsic and extrinsic. Fall prevention strategies are most often developed through the modification of extrinsic risk factors. In an article found in the Western Journal of Nursing Research that studies nurses' perceptions of fall prevention implementation and risk factors, two themes were discussed: the use of general fall prevention practices and inconsistencies in the use of these general fall prevention practices. When looking at the number of intrinsic factors listed to the left associated with falls, it is evident that individualized treatment plans could benefit patients and reduce the incidence of falls in the hospital setting. Some intrinsic risk factors include impaired balance or gait, history of falling, increased age, impaired cognition, depression, dizziness or vertigo, orthostatic hypotension, visual impairment, urinary frequency, nocturia, incontinence, and psychotropic medications. Some extrinsic risk factors include unit condition, diagnosis, lighting, cluttered environments, and use of restraints. Current practice. Common interventions used to aid in fall prevention include bed in low position, call light and reach, skid-free footwear, scheduled toileting, communication about fall risk, and specialist consults including PT and OT. These are all interventions that we all have used in our day-to-day practice. An article titled Fall Prevention Gap Analysis, Aiming for Targeted Improvements, looked at patient interviews and observations of nursing care to reveal that only 50% of patients recalled receiving fall prevention education. 37% indicated difficulty finding and using the call light, and 38% reported a prolonged wait for staff after using the call light. Nursing diagnosis. Ineffective health maintenance related to generalized fall prevention plans and ineffective staff communication, as evidenced by unmet goals for fall prevention in the acute care setting. Expected outcomes. Incidences of missed nursing care will decrease, and patient outcomes will improve through the use of effective leadership and delegation. Research evidence supports the association between missed nursing care and poor patient outcomes, such as falls, patient mobilization and feedings, hospital-acquired infections, and mortality. Nurse leaders and managers will demonstrate an improved understanding of leadership strategies and how these strategies impact the implementation of changes. Leadership is necessary when discussing the implementation of new practices. Complexity leadership provides a context of operation in which the behavior of leadership provides a context of operation. In which the behavior of leadership is to foster interaction from within the organization, increase network strength of the organization, and inject conflict to boost stability, creating the parameters and energy for constant change and adaptation. Nursing staff efficiently and appropriately delegate tasks to reduce the number of missed nursing duties. Medical errors are a leading cause of death worldwide, and many of these are the result of dysfunctional or non-existent teamwork. Implementation. Individualized care plans will be created for each patient that take into consideration individual risk factors. Training programs will be developed to identify a variety of nursing theories, including complexity leadership, transactional leadership, and transformative leadership. Delegation classes and simulations that include drills and staff-led discussions will be held regularly to allow for training and practice in a safe environment. Evaluation. Fall rates will decrease on all units, and nurses will describe an increased understanding of their patients' specific fall risks. Nurse managers and team leaders will demonstrate an understanding of a variety of leadership theories through competence exams and through an increase in the implementation of changes across unit staff. Delegation competence exams will be provided to all staff members regularly, and patient surveys will demonstrate a decrease in missed nursing duties. Conclusion. Evidence from literature was used to display the importance of leadership, delegation, and teamwork in the implementation of fall prevention practices to highlight deficits in the current fall prevention strategies. A plan that aims to reduce the incidence of falls in the acute care setting was presented, which uses effective leadership, delegation, and teamwork as the foundation of its success. In healthcare, if gaps in patient care that we are providing are identified, we aim to eliminate these gaps. The fall rates in the acute care setting clearly identify a need for changes to be made. Thank you for listening.